Hi friends, let's go and see few questions today as well. So you are assigned in ICU and you have got a ventilated patient, and this question is some of the measures what you can do to prevent ventilator associated pneumonia. That's a question. Okay, so there are certain steps you can do to prevent VAP. That is, first option is reposition the client at least every 2 hours to maintain a head of the bed upright 30 to 45 degree. Second option is promote nutrition with the use of a nasogastric tube and high caloric feedings. Third option is suction oral and pharynx secretions and provide thorough oral care at least every 2 hours. Fourth option is assess the client for sedation reduction and weaning extubation readiness. Fifth option is perform hand hygiene before and after care of the client and implement prophylactic intravenous antibiotic therapy. Let's go to each option one by one, why they are correct, and it's a SATA questions, like you will have more than one options correct. So let's go and see why those options are correct and the options are wrong, why they are wrong. Okay, so the see in ventilated associated pneumonia, position change, of course, it's recommended. So every 2 hours you are changing a position and keeping the head end 30 to 45 degrees. It's recommended. If means it is, if it is contraindicated for raising the head end, then don't do it, but changing the position every 2 hours. Okay, so helps to reduce. So why it is doing that, you should know the rationale. When you do anything, you should know the rationale why you are doing that. That helps to reduce the aspiration, secretion and gastric content. That is the reason you are keeping the head end up and changing, keep on every 2 hours you are changing the position. Okay, next is nasogastric tube was said. So nasogastric tube, when you insert a nasogastric tube, that is going to cause the patient another complication. It be sinusitis. The patient can develop sinusitis. So nasogastric tube, so orogastric is recommended instead of nasogastric. Orogastric, what it does, you can feed through that, and that decompress the stomach as well. Okay, so not nasogastric, orogastric is recommended. So option 2 is wrong. The option 3 is correct. Oral care every 2 hours. 2 hours you are cleaning, and if secretions are there and if it is not removed, it could be a source of infection. So, and this secretion can be aspirated. That's another. So it can make the patient can give VAP again for this patient. So every 2 hours position change, 2 hours oral care. Okay, and reduction and mechanical, if possible, remove the patient from ventilator as early as possible, because that will prevent further complication, long stay on ventilator, and too much use of sedation. That will make patient more vulnerable and make more complications. So you keep on assessing the patient and proactive and make a reassessment and recommend for the patient if patient is ready for weaning from the ventilator or not. Okay, that you can do. So the reduction in duration of mechanical ventilation and a reduction in sedation to assess the readiness of weaning have been shown to decrease the development of incidence of VAP. Okay, so after all, it's not you deciding to when the patient can come up with that physician, but you can assess and tell the physician that this patient can come up from the ventilator. Okay, so then the last option. Okay, hand hygiene is, yes, it is recommended for everywhere. Proper hand hygiene and the use of gloves is recommended, as been shown to reduce the risk of VAP here also. But what is here, there is something is wrong. In the option something was recommended is a prophylactic intravenous antibiotic. That is not recommended. That's why that option is wrong. But broad spectrum antibacterial oral rinse is recommended. You can use that for oral care. So that is recommended, but there is no recommendation of oral and intravenous antibiotics. So that's why this is wrong. Okay. So the position every 2 hours oral care, and checking the readiness of mechanical ventilator use and assessment and sedation weaning readiness is checking. That's all correct. Okay. Next question. Let's go to question. So now the night nurse on a medical floor has just received. She is going to get 4 patients. So which one she will assess first? She has a patient, an 52-year-old with pancreatitis, who is experiencing abdominal pain, rating 4 on 10. Okay. So pancreatitis, of course, abdominal pain is there. Is a symptomatic, means that is it is there as a other disease. So the next is 70-year-old underwent a transurethral resection of prostate TURP yesterday and having a burning sensation during urination. TURP patient, burning sensation. Okay. Then a man 78-year-old diagnosed with left-sided heart failure, who has developed a new non-productive cough and is restless. Patient is restless. A new non-productive cough. Okay, you have to go to each and every minute detail what is given in the question. Then 37-year-old female diagnosed with the cellulitis of left leg yesterday, who is experiencing redness and warmth of the left leg. So let's see who has to be visited seen first by the nurse. So the correct option is option number 3. The new non-productive cough and restlessness could indicate acute pulmonary edema. The nurse would assess the client first, focusing on lung sounds and heart sounds. You are going and auscultating the lung and heart sounds. Acute pulmonary edema is seen in clients that have a heart disease. Circulatory overload means if the patient is receiving a blood transfusion or IV infusion, anything that can cause pulmonary edema. The lung injuries that are post anesthetic lung injury and other etiologies that could bring about fluid in the alveolar that impedes gas exchange, that interfere with the gas exchange. If too much fluid there in the lung, then that will the pulmonary fluid will the amount of fluid will go high and interfere with the gas exchange. Okay, then the patient become what is that, restless, and will say that air hunger, all those things will appear. So this situation can be quickly escalate into a medical emergency. So the nurse should assure oxygenation and implement measures to decrease pulmonary congestion. That is action we have to do. We have to do all the measures to decrease the pulmonary congestion, and quick assessment and response are critical in preventing a medical emergency. So we have to, the patient can get more worse if you don't act as quickly as possible at this point. So you have to take care of this patient. Rest all patient can wait, but this is a critical situation. Okay. Then next is now the nurse knows that which of the following body system is responsible for the production of erythropoietin. So urinary system, cardiovascular system, lymphatic system, endocrine system. So this is a pathophysiology question. So urinary system is responsible for production of erythropoietin, which is a primary hormone regulator that promotes the development and differentiation of red blood cells in the bone marrow and initiate the production of hemoglobin. So 90% of the erythropoietin is produced by the lymphatic system and the renal peritubular cells, and with the other 10% is produced by the liver. Okay, the cell that produce erythropoietin are sensitive to the level of, they are sensitive, they can sense the level of oxygen in the body. If oxygen level is less, the kidney cells release erythropoietin to stimulate the, so what it does then it stimulate the bone marrow to produce more red blood cells to increase the oxygen carrying capacity of the blood. So the what happens here is the oxygen level is less, so we need more oxygen supply to the body. So if the oxygen level is less, the erythropoietin, so that will stimulate the bone marrow and tell the bone marrow to produce more RBCs, red blood cells, so that the manpower is increased here. So, but each RBC is carrying little by little, not the amount which they were carrying before this situation, but they are carrying little by little, but it is taken by many people. So, like that it is compensated and the number of RBCs are increased. Okay, that is the what is this called, oxygen carrying capacity increase of the blood. This is how it is compensated here. So the other cardiovascular, lymphatic and endocrine system are not responsible for producing erythropoietin. Okay, now let's go to next question. Here you are the nurse with a patient who is allergic to penicillin. Okay, your physician has ordered cefazolin, the initial dose he ordered, and he went away. So the nurse states that the patient state that when she takes penicillin, she feels short of breath, allergic to penicillin, and the nurse notes that the patient is allergic to penicillin, that he started become little short of breath and itchiness after receiving the penicillin. So, and what a nurse has, you got a new order for cefazolin, so what you have to do? So here, call the pharmacy to therapeutically change the medication and notify the physician of this change. So do you think the pharmacy is responsible this? Who ordered this? The physician ordered. So who will be the one is acting here? The physician. Yes. So next, the nurse order is in place. That doesn't mean that you go give and the patient is go straight away you go and give. No, when the patient stated that she is allergic, you should do something. So you don't give the medication. That is the first thing you have to do. Hold the medication and call the physician to double check the order. Okay, that's what the nurse has to do. Then the third option, if give the medication as ordered, cefazolin is not a penicillin. Then the fourth option is, after asking another nurse, give the medication as ordered. No, you are not checking with another nurse and give the medication order. No, never do that. First, if something is not clear, hold it, contact the physician, ask him for check the order, double check the order. Okay, then you can do. Pharmacy, okay, you can ask pharmacy for some questions, but not the order is done by the physician. Need something change in orders or something is there, something is concerned, then you have to contact the physician. Okay, the penicillin, cefazolin is not a penicillin. Okay, it is a first generation cephalosporin, which can cause a reaction. If the patient who has a reaction with penicillin, this patient can have reaction with the cefazolin also. So that also keep it in mind. Okay, so it's the cefazolin is not a penicillin, it's the first generation cephalosporin, which can cause a reaction in clients with the penicillin allergies as well. Okay, the next question. A 52-year-old woman admitted with a new diagnosis of GI bleed, gastrointestinal bleed. The physician has ordered a client to receive 2 units of packed RBC. So here this patient hemoglobin is 6.8, that's why she is receiving blood transfusion. But the blood transfusion was started at the rate of 100 ml per hour. After 15 minutes of starting infusion, the patient started feeling chilled, then shortness of breath and experiencing lumbar pain, rating 8/10 scale. What is the nurse responsibility here? So you picked up this patient is having hemolytic reaction. So first thing what you will do, you have to stop the infusion. Yeah, because the more you give the blood, it's going to kill the patient. So first and foremost, if you see the patient is started developing hemolytic reaction, first thing is what you have to do. You have to stop the infusion. Let's go to the options, by the way. Obtain vital signs and notify the physician of potential reaction. That you have to do, but that is not the first thing. Okay. Slow the infusion of 75 ml per hour. Reassess in 15 minutes. No, you have to stop it. Not slowing down or not decreasing the infusion. Then stop the infusion and run a normal saline to keep vein open. Okay, that is what you have to do here. Option number 3, that's the correct one. Administer PRN pain medication as ordered. Apply oxygen at 2 liter per minute and provide an additional blanket. Okay, that's not the one, but there are certain things you can do, but first is you have to stop. Okay, so the vital sign should be obtained, and the first option, the vital sign should be obtained and is a physician notified after treating is discontinued. Unit is question should not be the unit in question should not be restarted, and any other units have been issued should not be implemented. Means some institution they will stop